First, I would like to start with some basic figures and facts about the health sector in the European Union. A very important sector from an economic point of view. It employs a significant amount of workforce, 15 million people. That is actually much larger than other domains, retail and business services. Equally important, the amount of resources that go to healthcare across the Union is very significant, about 9% of our gross domestic product, and that grows very fast, much faster than our economy. And equally important again is the very low penetration of information communication technologies in this sector, comparatively speaking to other sectors again. And this is something that we actually tried to address, have been trying to address for many years now. So the application of ICT in health, e-health as we all say somehow, it is a growing industry, it is a fast-growing industry, but at the moment it is only 2% in terms of healthcare expenditure. Across the Union, and these are recent figures, the overall expenditure is about 1,000 billion euros. And about only 20 billion out of this is dedicated into e-health investment. Now, this figure will grow. There are estimations that it may reach 50 billion by the year 2010, 2011. Most of it at the moment, it refers, 80% about, refers to infrastructure put in place for administrating the back office, putting in place the networks that link healthcare professionals, electronic records, and so on. And very little is for providing personalized care and telemonitoring services. So the Commission has been working in this area of e-health for about 20 years now. We supported the work on regional health information networks, electronic health records, and so on. And at this moment in time, we are trying to support the deployment of all the results that have come out of FP3 and FP4. We are talking about a delay of 10, 12, sometimes 15 years from the moment a project produces some sort of results until they will eventually be used at a wide scale in practice. That's the kind of lag that this healthcare sector experiences. It's a conservative domain. It does not happen in other sectors, but this is where we are, okay? This is what we live with. At the same time, we continue to support research, in particular in two main domains, personal health systems and virtual physiological human. And in this presentation, I will focus on the first one, but for your knowledge, both of them actually refer to the topic of personalized healthcare. So a little bit of background. This is how it all started. And for about 10 years in the 90s, the focus was to try to link all these people that are involved in healthcare, to try to exchange information more efficiently between them, try to avoid errors that are not necessary. So a lot of effort in putting regional networks and national networks in place to link GPs, hospitals, pharmacists, and actually to start supporting the first wave of home care applications. As a natural step after that was the introduction of the individual person in this sort of network as an active node. An active node in the sense that the persons are really responsible in providing information, in responding to recommendations and interacting with the other actors in this network. This is how the concept of personal health systems was born out, in a sense. A concept that places the individual person in the center of the healthcare process. And what it aims to do is to make better use of the available resources in order to provide high quality, personalized care at a point of need. We see the personal health systems as a main platform and facilitator to achieve what is continuity of care, both in space and in time. In space means outside the hospitals, in their ordinary living environments, homes, whatever. And in time, by making the information, diagnostic information, vital signals recording, more available, more periodic, more frequent recordings, even continuous if necessary. And also personal health systems are for supporting chronic disease patients, but also for supporting those who want to remain healthy. So there is a preventive element into this as well. What do they mean for the individual person and for the health professional? For the individual person, first of all, allow them to be better educated about health matters, about conditions that may affect them. And then let them be more active in dealing with their conditions or managing their health. That means more responsible attitude to that, but also the word that we heard before from Niels, the responsibility that these people can have in dealing with this. It's not only, though, something that is enclosed to themselves. Personal health systems allow the individuals to have a better interaction with doctors in terms of exchange of information, following advice, and so on. And for the health professionals, they are also very influential. They are not to be seen as something that replaces them and as a threat. Personal health systems make information that was previously unavailable to them, perhaps more comprehensive monitoring information, and that can help them in making better decisions and offering more effective care. These systems come from the integration of various technologies, sensors, actuators, communications, user interfaces, signal processing, into wearable, implantable, portable devices that are used by the individuals themselves, but they are within the framework, the overall umbrella of telemedicine platform and personalized services, in order to be able to provide to these people the care tailored to their needs, whether this is a personalized advice, treatment in terms of dosage, drug, or whatever. And of course, making this available outside hospitals. If I try to illustrate this in kind of a schematic way, you can see three main blocks here. I start with the one on the left, data acquisition. This is the starting point because this is where we get the information, the raw data. On the basis of this, we can proceed further. It can come from various sensors, measuring health status, measuring activity, and so on. The second very important step is the processing of this information. First of all, we do not wish to create a burden to the people who will receive it, yeah? So we have to avoid overload. So extract what is meaningful, clinically useful out of this. And this is where we need to correlate it with medical expertise. This processing can be done locally by, let's say, on-body electronics, or it can be done remotely at call centers, dedicated call centers, where the facilities can be more advanced, and when people can actually be dedicated to monitor the data. Then we have several elements of communication. Communication of useful data from, let's say, the call centers to doctors, who can make certain decisions, adjust treatment and so on, and then communicate this back to their patients. But also communication directly from the onboard electronics back to their users in the form of personalized advice for lifestyle adjustments, for example, or in the form of actuating the appropriate dose of medication, of insulin, in the diabetic population. At the end of the 90s, or even a little bit before that, we had seen the first approaches in this domain. They employed portable devices for home use, like